Yes, all right. So we're going to attempt to cover metastatic breast cancer. What I'm going to do, since we can't cover all of it, is tell you updates on some interesting trials and some interesting science that's going on. And I will, conflict of interest, and then I will intend to offer you my opinion on treatment sequencing, and then I want to end with an interesting trial on comprehensive molecular profiling. So hormone receptor positive breast cancers. This data was presented at San Antonio, and again, it's mainly on the ribociclib Mona Lisa suite of studies, but in general, I personally think of the response across the CDK4/6 inhibitors to be very similar. But what they've done here in this particular trial, and I think Lisa Carey presented that, is look at the subtypes of hormone receptor positive breast cancer. In here, we talk about the luminal A, luminal B, HER2 enriched, and then the basal-like, and how those patients behaved from a clinical standpoint on the studies. So here we have on the left, in the placebo arm of those studies, we see the luminal A doing much better, luminal B, HER2 enriched, and the basal subtype all sort of together. In the ribociclib, so the patients who got the CDK4/6 inhibitor, most of these subgroup moved up and did much better, except the basal-like. We all have those patients, if we treat breast cancer, who we anticipate would benefit from chemotherapy, from the CDK4/6 inhibitors, but who don't. I suspect they fall in that group. That doesn't necessarily impact what we do, but again, it's something that we could think about, and that population probably need chemotherapy more than anti-hormonal therapy. The PATA-1 study, which Lee talked about, I'm not going to go in great detail, but that was a very interesting study. Again, that study, patients were given CDK4/6 inhibitor, in this case palbociclib, with an aromatase inhibitor, treated, had sequential circulating tumor DNA done until an ESR mutation was detected. And then those patients were randomized to switching to fulvestrant or continuing the aromatase inhibitor. As Lee showed, importantly, the fulvestrant arm did better. But interestingly, the authors and researchers decided, okay, let's see. In the arm that continued on the aromatase inhibitor, if we then switch them to fulvestrant and palbociclib, could we rescue them? And the answer is no. All right? We couldn't rescue them after they've progressed. So essentially, that portion of study, that orange here, that 3.5 months, is really a second-line Faslodex data. All right? Keep that in mind when we talk about the next trial. So the next trial we're talking about is the Emerald study. And it really is the first phase 3 study in the metastatic setting to show the benefit, the clinical benefit of an oral SERD. Lee talked about those. Fulvestrant, selective estrogen receptor downregulator, which is an intramuscular shot. This is the oral version of it, essentially. And those patients were randomized to elacestrant versus standard of care. And in this case, it could be fulvestrant, anastrozole, letrozole, and exemestane. This was mainly a third-line patient population, all right? Most patients got fulvestrant. So really, it's a comparison of elacestrant versus fulvestrant with a primary endpoint of PFS in all patients and in patients with ESR1 mutation. Here's what the study showed. So interesting, you see that really sharp drop? There is a group of patients for whom neither of these therapies work. So that's why we see this really sharp drop. But then the patients for who get benefit out of it, there was, and is this my laser? So in the standard of care, 1.91 months, so the fulvestrant only arm only had about a 2 months improvement in PFS, and there was a benefit about a month in, that's all patients, for the addition of elacestrant. And that was statistically significant, by the way, okay, with the p-value here of 0.0018. I asked you earlier to take a look at that 3.5 months benefit for the addition of fulvestrant to palbociclib, because a lot of, especially me, when I first thought of it, I thought fulvestrant only in standard of care in a third-line setting, 2 months, that is low. But we just saw in a second line, fulvestrant plus palbociclib, that was really 3.5 months. So that is not too far off. And there's some other studies that actually point that this is not too far off. Look in the ESR1 mutated patients. There was an even 2 months better improvement in PFS with the addition of the ESR1 mutation. I tend to think that the ESR1 mutated tumors are so heavily singly dependent on that pathway that when you inhibit it, they do better. Whereas the non-ESR1, as Lee talked about, there are lots of crosstalk going on, that there may be other pathways going on there, and those patients don't really fully benefit as much, not all the patients, from the oral SERD. That's my opinion here. So in summary, what I've shown here for the hormone receptor positive, there's consistent benefit for ribo and anti-estrogen therapy across all subtypes, except the basal subtypes. Again, still investigational. The pattern 1 study lets us know that ESR1 mutation is important clinically, and that fulvestrant is a better drug versus the aromatase inhibitor. And in the Emerald studies, the first of its kind, showing that oral SERDs are really active, and they're going to be part of your arsenal in the very near future. So, all right, how do I, again, and that's my opinion, and in the metastatic patient population, there's going to be a lot of argument to it. I do think CDK4/6 inhibitor is the standard of care in a first-line hormone receptor positive patient. Fulvestrant, if ESR1 mutant, if in my practice we do it up front so we know we'd switch from an aromatase inhibitor to a fulvestrant instead if that patient has an ESR1 mutation. In the second line patient population, Lee talked about doing germline testing. If that patient has a BRCA mutation, you can use olaparib if you want to, or continue on the estrogen, anti-estrogen pathway. Me, I tend to continue the anti-estrogen pathway. Again, there are tamoxifen, aromatase inhibitor, fulvestrant, and then third line, again, you have your choice. Eventually, we go to chemotherapy. I do want to add abemaciclib as single agent is also approved in that setting. Again, clinical trial, continue them. We do have a suite of oral SERD clinical trials. Again, and there are drugs being considered out there. If you do have them, please consider that. In the triple negative space, I want to talk about the Keynote 355. As you remember, this is a study that looked at metastatic triple negative patients, randomized them to pembrolizumab, to chemotherapy, that's first-line patients, versus placebo plus chemotherapy. And the chemotherapies were taxane or gemcarbo. Here we showed there was improvement in PD-L1, mainly in the greater than 10% CPS score versus the greater than or equal to 1%. There was also some overall survival benefit in that population. Recently at San Antonio, the question was, based on how the study was conducted, greater than 10 showed improvement. Is there a section in between the less than 10 that also had some benefit? And here we have the breakdown across the study of the percentages of patients that fit within the category. CPS less than 1, between 1 and 9, 10 and 19, and that little, whatever is here is supposed to be 20 and greater. What that showed essentially, and we'll just go to from the 10 and 19 and the 20 or greater, that's really where we saw the benefit. So when you're selecting your patients in the first-line triple negative for pembrolizumab and chemotherapy, really the CPS score of 10 is important. Patients less than that don't really get any benefit. Again, the same thing is seen for overall survival. The benefit is really at 10 or greater. I also want to talk about the ASCENT trial. Sacituzumab has been part of your arsenal for a little while, but this trial really cemented its approval from the FDA. This is really a second, third line patient population, metastatic triple negative, where patients were randomized to sacituzumab versus physician's choice of treatment. And down here I have what most patients got, really eribulin vinorelbine, gemcitabine, and capecitabine. By far, the drug of choice in the physician's choice was eribulin, with PFS being the primary outcome. This study was stopped early because of instead of saying the poor performance of the standard of care, I would say the exceptional performance of the treatment arm. Here's what we see: improvement in PFS for sacituzumab over treatment of physician's choice, with almost a 60% reduction in risk. That was also seen, a similar benefit was seen for overall survival. Summary, Keynote 355, if you're going to use pembrolizumab with chemotherapy, really you have to use it in CPS 10 or greater. Sacituzumab is a really good option. The FDA on study patients who had neoadjuvant chemotherapy and progressed really quickly, the neoadjuvant chemotherapy was considered a line of therapy. So the FDA did allow for approval in the second line and beyond. So you can use it there. Importantly, though, it is an ADC, antibody drug conjugate, but it is toxic, similar to what you would expect for single-arm chemotherapy. So here, first line, metastatic breast cancer patients who are PD-L1 positive, pembro plus chemo. I do recommend that you do for your triple negative comprehensive molecular profile up front, because it does help us make a decision about our patients. If your patient has a BRCA mutation, so there's always some controversy there about whether if your patient has PD-L1 positive and a BRCA mutation, which one you use in the first line. My view of the current data would suggest that you use pembrolizumab first, and here's why. The Olympiad and BRCA study was really a second line and greater, although there was first line patients in there. Most of the patients were second line patients. The pembrolizumab, what we know with the immunotherapy in triple negative is the earlier you use it, the better. We see it's approved in the in the curative setting. It has data in the first line setting. Really, data in the later line setting have been negative. So I think you use it up front and then use olaparib after. Chemotherapy, and you can see them over here. Clinical trial, always consider clinical trial for your patients, even if it's first line. Second line, olaparib, if they didn't get it in the first line and they're BRCA mutated, sacituzumab chemotherapy, and we can see again, clinical trial, clinical trial, clinical trial. HER2 positive. So what we have here, and again, I'm just going to select some study. I want to talk about the Destiny-03 study that was first presented at ESMO this year. Our standard of care, this is a second line HER2 positive patients who had gotten taxane plus Perjeta and Herceptin in the first line setting. Our traditional second line drug had been Kadcyla. This study was comparing what we call TDXD, brand name Enhertu, versus TDM1 in that patient population, with PFS being the primary endpoint and a secondary endpoint of overall survival. I expected Enhertu to best TDM1. I didn't expect it to destroy TDM1. So what we see here, again, and this is in central review, this is PFS by central review. There is the median PFS had not been reached. By investigator analysis, I think it was about 24 months versus about 7 months in the TDM1 arm. This is now and should be our standard of care for a second line patient. All right, there are some patients for whom we may not think of it just because of tolerability issues, but that should be our standard of care. Again, Enhertu, I know for me and for a lot of physicians using this drug, the data from about the pneumonitis was comforting for me, because in the phase 1B study that had this drug get early approval, there was concern about pneumonitis because 5 patients were reported to have died because of pneumonitis, and we're reporting somewhere upwards of 15% of patients were getting symptomatic pneumonitis, at least pneumonitis on the study. What it shows here in this randomized study is about 10% of patients got all grade pneumonitis in the treatment arm, with most of it being grade 2. That's symptomatic, where you are making some intervention, but that's not urgent, where patients need to be hospitalized or need to be on oxygen. There was no difference really in ejection fraction. Importantly, on this study, patients who had treated and stable brain mets were included on the study at San Antonio. They looked at how those patients did centrally in terms of responses. What it did show is that if you got TDXD and you had brain involvement that was treated and stable, you did get some response in the brain. We do also see some response on TDM1, but most of it was TDXD, again, bested TDM1. I want to talk about, since we're talking about CNS disease, HER2 CLIMB study, and I think Lee talked about tucatinib in one of the studies that are ongoing in the adjuvant setting. This study looked at a TKI called tucatinib with trastuzumab and capecitabine versus trastuzumab and capecitabine in a metastatic really second and third line patient population. 60% had hormone receptor positive, 48% had CNS metastasis, 36% de novo, median about 3 prior lines of therapy in the metastatic setting. These were the outcome. In summary, we had an improvement in PFS, about 46% risk reduction. Overall, in both PFS and overall survival, there was about a 34%. And for the patients who had brain metastasis, there was also about a 52% improvement in PFS. Looking purely at the CNS disease, CNS PFS, that is response in the brain. Again, those patients were on this study. Patients could be untreated, treated, untreated or treated, or stable. What we see is that CNS-wise, just looking at how this patient behaved in the brain, there was an improvement in CNS PFS for the addition of tucatinib to the standard therapy. Not only for PFS, but overall survival in brain mets. In the patients with active brain mets, there was also improvement for both PFS and OFS. In the stable disease, I don't think I have that in there. Those patients had improvement in PFS. We didn't see that in OS, but again, small numbers. I think neratinib study, and I'm going to just run through this. Lee spoke about neratinib earlier. Again, it's a HER2 positive TKI, irreversible, as opposed to lapatinib, which is reversible. This drug was selected for a population of patients who have HER2 activating mutations. Very small population, so this study took a while to complete. They were either, there was an arm who were hormone receptor positive with this mutation. They got neratinib, fulvestrant, and trastuzumab. There was a second arm where there was randomized to the addition of neratinib to fulvestrant and trastuzumab, or fulvestrant, trastuzumab, versus fulvestrant. And then there was a triple negative arm who just got neratinib and trastuzumab. So in summary, in the neratinib plus fulvestrant and trastuzumab in the hormone receptor positive group, we had, although we didn't have any CR, we had about 12 partial responses with a median, with a clinical benefit rate about 57%. So those patients, and an objective response rate about 46.2%. So this is an active drug in a patient population with a mutation in the HER2 protein. For the triple negative patients, again, we see benefit. We actually had one complete response in that population. Most of the mutations were really in the kinase domain, and you can see for the complete and partial response, the circles there, most of them were in the kinase domain. Again, we talked TDXD, standard of care, patients with brain mets. Again, if you have a patient on TDXD with brain mets, you can feel comfortable that they may have some activity in the brain, but tucatinib is really standard of care for patients with brain mets. Neratinib, if you have a HER2 mutant. In terms of how I see the current landscape for treatment, gold standard first line, taxane with trastuzumab and Perjeta. We have some ongoing studies comparing the drugs that we talked about to that, but that is still standard of care. In the second line, it really is TDXD. Personally, if a patient has brain mets, I also tend to try to use tucatinib in that population. I think that is fine, and that's a decision that you make with your patients. Some patients have actually used TDM1, the older patients where toxicity is an issue. Third line, TDM1, tucatinib, neratinib. We didn't talk about magitoxumab, but that's another antibody that's approved in that third line setting. And then you have a suite of other options. Last study I'm going to talk about is this genomic profiling study. And I think it is a very interesting design. Lee talked about earlier the use of molecular profile and what we've seen at West Experience for patients, how it made changes to what we do. This is the first study that I remember, and I think it might be the only one, that actually took patients who were, those are metastatic patients, who got chemotherapy and are either responding or have stable disease. A molecular profile was performed, and based on their profile, they were either switched to a target or continued on that chemotherapy that they were getting some benefit from. All right? The choice of therapy, the choice of profile or targeted therapy was based on this SCAT score from ESMO. So essentially, it's tier 1 or tier 2, where there is an association of outcome in clinical trials for that particular drug, or for the alteration match is associated with anti-tumor activity, but the magnitude of benefit is not really known. Here's what it shows. If you were able to treat the patient based on their mutation, they did better than if you continued the chemotherapy. I think that gives us evidence that molecular profile in our patients, especially our metastatic patient, is important. Again, through most of the subgroups, there will benefit. So in summary, first randomized trial for this particular showing the utilization of molecular profile in select patient with metastatic breast cancer has improved clinical outcome. I didn't show that data, but the HRD-LOH, loss of heterozygosity, was associated with the longest PFS on that study. Molecular profiling for metastatic patient is imperative and clinically beneficial. And like I said many times, my preference is to do it upfront, first line, because it can change therapy. It also allows us to better anticipate what our next therapy is, and it can shorten what you give the patient the next time. If you already have the data, you don't have to try to get the tissue to think about and start your patient on their second line.